Well, welcome everyone. Thanks for joining us. Thanks for joining Walker today for our presentation of MATMAR. Yeah, it's a hot topic. So I'm Brianna. I'm the accreditation coordinator for Walker with Washington Alliance for Quality Recovery Residences, as well as assistant of professional development. So I help out with these webinars. I wanted to start out, if people feel willing to introduce themselves, maybe what organization you're from, the county, and then also like, what are you hoping to learn today? So that way, perhaps if we don't get all of what you're hoping to learn, we could do another one later on. So yeah, that'd be great. And Garrett is our presenter today. So there he is.
Hi, everyone.
Garrett Kostin, he's an MSW. He started his social work career with migrant and refugee communities in the Thailand-Myanmar border in 2009. Since returning to the US in 2014, he has gained valuable experience working in both inpatient and outpatient behavioral health and medical settings. He currently serves as a behavioral health and health consultant, facilitating workshops and trainings on person-centered and trauma-informed care, motivational interview skills, medications for opioid use disorder, and other topics. So he's really energized by innovative person-centered initiatives that aim to reduce disparities and inequities in healthcare and society. So we're so grateful he can be here today and share on this topic.
I can't hear you.
Garrett, you can go ahead.
Yes. All right. So I just want to reiterate Brianna's invitation to everyone to introduce yourself in the chat box, especially what we're interested in is what you are hoping to learn about this topic, about medication-assisted recovery, so that if we aren't able to cover everything today, we can consider if a part 2 is warranted. First of all, I want to say how grateful I am that of all of you for attending. This attendance is great. Oh, how long was I muted there?
Just a couple seconds. You're okay.
Okay. All right. So this is the third presentation I've been invited to do for Walker and recovery residence operators, and by far the greatest turnout. So I'm really pleasantly pleased to see you all here today. I do want to thank Brianna and Jason from Walker for having me back and for this opportunity. And for all of you, whether you are recovery residence operators, stakeholders, treatment providers, or just folks eager to learn more about this topic, we're very happy to have you in attendance today. I'm going to go ahead and share my screen, share my presentation to get started. If anyone has any problems with hearing or seeing, please, you can quickly unmute yourself and let us know about the problem, or send a message in the chat box that Brianna is going to be monitoring. All right, so hopefully right now you all can see full screen presentation. This is understanding and supporting medication-assisted pathways to recovery. I am Garrett Kostin, as Brianna said. I actually have now completed the credentialing process. I am a fully licensed independent clinical social worker, LICSW, as well as an SUDPT. Hopefully that I'll lose the T before the end of this year. And I'm a behavioral health consultant. I wanted to share a little bit about me and my relationship to this topic to give you a better idea of my perspective and where I'm coming from. I worked as the lead care navigator for a medication-assisted treatment program in Seattle called the MATCH program from 2017 to 2019. I was part of the original team that got this program started. It was a grant-funded program. And that was my crash course in learning everything about medication-assisted treatment. The program I worked with focused on medications for opioid use disorder. So I do have a little bit more specialization and experience with medications for opioid use rather than medications for alcohol, but we will cover both today. This topic is dear to my heart because I saw how this topic of medication for treating addiction is controversial in the recovery community. A lot of people have a lot of strong opinions about recovery, and it takes some sensitivity to navigate that. Although I believe we can do that with respect and compassion. For me, myself, working as a care navigator, helping individuals get started on these medications, help them get connected to treatment, and help them with additional resources and sober support, I confronted that misunderstanding, that stigma, and even some contempt from my own colleagues who worked for the same agency. I remember being told by one member who worked with a different program at the agency. She said it seemed to her that we were encouraging our clients, our patients, to stay on drugs. And so that was really an eye-opening conversation for me in the way that misconceptions can exist about medication-assisted treatment. So to continue on, first, I'd like to give you an overview of how we plan to spend our time together this morning. First of all, I'd like to talk about why this topic is important, why this is relevant and important for all of us to understand and be comfortable with this topic. We'll review some of the key terms and acronyms and relationships between different concepts. I'll outline the goals and also the outcomes of medication-assisted treatment and medication-assisted recovery. We'll touch on some of the common misconceptions and controversies. We'll then go into more detail about the specific medications that are available and can be prescribed for folks with both opioid use disorder and alcohol use disorder. And then we'll save a good amount of time towards the end to focus on the really relevant stuff about medication-assisted recovery in recovery residences, some tips and suggestions and guidance for operators and staff. And we'll also have a good chunk of time at the end for questions and discussion. I'd like to, before we move on, I hope that there's lots of questions and that there's things that you want to share and add to this discussion. Please, I ask you, if you're concerned about forgetting your question, go ahead, feel free, put it in the text box, in the chat box. Brianna's gonna be monitoring the chat box and we'll call out questions if they're real important or relevant or save them for the discussion time. You're also welcome to save your questions and comments for the discussion period at the end, and we'll have a little break in the middle. All right. So on the topic of why this topic is important, here are some answers to the question of why this topic of medication-assisted recovery is important for us to be learning about and discussing today. First of all, medication-assisted recovery has been proven through exhaustive research to be a safe and effective pathway to long-term recovery for many individuals, and it's also been demonstrated to work best at the treatment of opioid use disorders. There, as I mentioned about misinformation about medication-assisted recovery, that has the unfortunate effect of feeding stigma and discrimination against this pathway to recovery, which unfortunately limits access for some people or prevents them from seeking these life-saving treatments that could benefit them greatly. We also hold that the exclusion of people from the recovery community and related support and housing opportunities based on their use of medications is unhelpful for public health, for the recovery community in general, and for society in general, and also illegal in many cases. There is also something that is common to see with this topic of medication-assisted recovery is the mindset that if somebody does use these medications, it's best if they only use them for a short time, and maybe we should encourage them to get to the point where they're ready to taper off the medications and continue their recovery without the assistance of medication. That can actually be very unhelpful. It can be harmful. If somebody prematurely stops these medications before they're ready or before they've fully made a plan with their treatment team, they will basically reset their tolerance and leave themselves at high risk for overdose if they do have a relapse. So we want to bust that myth that these medications should, if used at all, should only be used for a short time. In the next slide, I'm going to show you some more startling figures, but one reason why this topic is very important is because the opioid epidemic and the concomitant rise in overdose deaths is continuing both state and nationwide. And finally, it's important to work on expanding and welcoming new potential members of the recovery community with open arms, rather than practicing exclusion or discrimination. And so with that, I'd like to just share a pretty stark visual of where we're at in terms of the deaths caused by drug overdoses. This is not only deaths by opioids, although death by overdose on opioids accounts for about 70% of these deaths in general in Washington state. We can see here that from 2019 to 2020, overdose deaths across Washington state increased about 37.5%. And then again, from 2020 to last year to 2021, it increased again about 21% to now more than 2,000 deaths annually. That averages out to 5.7 deaths by drug overdose per day in the state. And the figure is about 265 overdose deaths per day in the country as a whole. So before we move on, it's very helpful to make sure that we're all on the same page with some key terms and some of the common acronyms that we'll be seeing here today. So to begin with, you'll see in this presentation, or we'll use the acronym ABT. That stands for abstinence-based treatment, which is the traditional model of recovery that was largely influenced by Alcoholics Anonymous in the mid 20th century, and has been really influential in affecting the culture of the recovery community today. So an abstinence-based treatment model is based on the complete refrain from using substances of any kind, alcohol and otherwise. And that abstinence is most often coupled with extensive peer-based sober support, such as 12-step groups, peer support groups, etc. MAT, or MAT, stands for medication-assisted treatment, which the definition of which is the use of an FDA-approved medication to support the health, safety, and recovery of an individual with a substance use disorder. So MAT, really, we're talking about the medication as treatment, the straight medications. And we have another term, MAR, or MAR, which stands for medication-assisted recovery. This concept sort of expands on the use of medications to assist in addiction treatment, to give credence to the importance of adjunct support besides the medication. So when we talk about MAR, we're talking about the use of an approved medication to support the recovery of an individual with a substance use disorder, that while also emphasizing that individual's engagement with abstinence-based recovery supports. So when we're talking about MAR, we're talking about an individualized recovery plan that includes the medications, peer-based sober support, and also professional psychological or behavioral treatment like counseling. Also harm reduction, we'll talk a little bit about today. Harm reduction is referencing practical strategies that are aimed at reducing the dangerous and or negative aspects of substance use. Harm reduction is not considered a pathway to recovery on its own, but it's considered something that's like a half step towards hopefully getting someone closer to that goal, or at least reducing harms to themselves while they're continuing to use. Up here so last night I was reviewing this and I realized, oh, there's more acronyms than I even noticed at first. So up in the box here, you'll see a couple more. For RR stands for recovery residence, OUD is opioid use disorder, and AUD is alcohol use disorder. So let's talk about how these concepts, how these different recovery pathways work together, how they're related. In the first graphic here, this here is it's obviously a Venn diagram, but it shows how we have the traditional recovery model of abstinence-based treatment, and then we have the introduction of medications that can support sobriety and recovery. When we put those together, the abstinence-based treatment and ideology with the acceptance of medications and the usefulness that they can have in treatment, combined together, that is considered MAR, or medication-assisted recovery. It's the use of prescribed medications as an aid in sustaining sobriety, while also the individual participates in sober and recovery services and supports. The next visual here on the right-hand side, this little three-legged stool, this is my representation of what the current gold standard or standard of care for the treatment of substance use disorders looks like, especially for opioid and alcohol use disorders for which there are medications. The framework of that's currently the gold standard, believed to be the most effective for the treatment of disorders, utilizes medications as one of the three primary legs of the stool, psychosocial services and treatment, such as counseling or therapy to get at some of the underlying causes, what might be the drivers of the addiction for the person, the abuse, trauma, or co-occurring disorders that might be impacting their life and contributing to their substance use disorder, and also that peer-based community sober support to foster accountability, build community, and to help the person in recovery gain some sobriety skills. All of those together, the three legs have equal importance. And really, without any one of those, the whole stool is going to collapse. So to expand on that idea of the three-legged stool as the current evidence-based standard of care for the treatment of opioid use disorders, especially, this is a visual that I found from SAMSA, the Substance Abuse and Mental Health Services Administration of the U.S. government. This is how they visualized the standard of care of medication-assisted recovery. Obviously, it's a little bit different, but you see the three main categories of the medication, and then in the middle, the psychosocial therapies, and lastly, the community-based recovery supports. The arrows between the circles are actually very important. That they represent coordination between providers of the three categories and working together for the benefit of the individual. If any one of these three legs or three sections of the treatment are not in coordination or are not communicating well, working well with the other two, the outcomes are not expected to be as strong. Okay, so at this time, before we go any further, I'd like to activate activate you and call on you to sort of contribute and energize this conversation. Let me go back. So for the next 4 or 5 minutes, I'd like to hear from as many people as possible about your ideas, positive or negative, about medication-assisted recovery, your opinion about it as a viable pathway to recovery, any concerns you might have about MAR, anything that you can share that gives us an idea of your foundation on this topic and where your perspective, where you're coming from. So whoever would like to just unmute yourself and briefly share, that would be wonderful.
Hi, I'm Sheena. So I am an advocate for Cocoon House. I'm also a member of Narcotics Anonymous and have a very widespread network in Narcotics Anonymous. I have some sponsees of my own that I help support, a few of them who are currently in MAR, like medication-assisted recovery. There is somewhat of a stigma inside 12-step programs around MAR or MAT, and it's kind of a shame. I have a few sponsees that are currently going through that program, and with like the help and support of their community and the people who aren't like judgmental of it or whatnot, like they're doing really well in their recovery as long as they're taking their medication as subscribed and they're working on tapering off of the medication. Like, I think that it's super helpful for a lot of people because they don't have the ability, the strength, or the courage in order to let go of opioids on their own, right? So this is a way for them to do that in like a healthy way that's not going to cause them a lot more medical harm. And I'm really all for this program.
Thank you for sharing your experiences, and I'm glad to hear some of your friends have had success with MAR.
Absolutely.
Yeah. Anyone else? Any positive or negative impressions or opinions about MAR?
I'm Capitola Barge, and I work for Reliable Enterprises. I do homeless. One of my concerns are when somebody is on Suboxone, how do you tell if they're taking too much? So I have a client who nods out on it. So if that is something that you're supposed to do, they prefer a high dose, and sometimes they're misusing it. So, like, how do you discern that? How do you approach that?
All right, thank you. That's a great question. We're going to touch on that down the road in this presentation, but I can just tell you real briefly that in my experience, and again, I'm not a medical professional. I'm a social worker, but my experience and my knowledge about Suboxone is that somebody on a therapeutic dose, a dose that holds them and keeps them from experiencing cravings or symptoms of withdrawal, should not be nodding out regularly. I would share your concern or your thought that might be a higher dose than is necessary. At the beginning, when somebody is first prescribed MAR, there is some work that needs to be done to figure out what is the best therapeutic dose for them, the dose that basically keeps them feeling well and comfortable, but not experiencing euphoria or sedation, like nodding off. And my tip for that, we'll get to this, but my tip is to try to coordinate with the provider, with the individual's treatment team. You'll need to get their signed permission to do so, but you can then discuss your observations and hear what the individual's treatment team thinks about their dose and whether or not it's appropriate.
Right. Well, thank you. And so I'm totally for MAR. It's been a little confusing.
Well, I'm really glad you're here. Hopefully we will clear up some of your confusion and send you on your way with a lot of information. And we especially seek to hear from you if there's things that we didn't cover that you would be interested in today. How about one more person?
Garrett, there's a couple of comments in the chat.
Oh, great.
I wanted to see, does anyone else, your audio is coming in a little scratchy, just randomly. Does anyone else experience it, or is it just on my end? If you maybe.
My audio?
I'm hearing it's kind of scratchy.
Okay. Maybe Garrett, if you try disconnecting the audio and reconnecting it, or yeah, maybe that too. I don't know.
How does this sound now? Is that better?
Oh, yeah. Yeah, that must
Okay.
have been it. The headphones given some something going, but I can read some of the comments here. So Steve said, as a clinician, I really see the success and outcomes when MAT and counseling are together. It's like 1 + 1 = 1,000. Sean said, I find that it's pretty effective, though there are still a small percentage of people on MAT who still continue to use, and it increases the chance of OD, which is a concern. I love to hear what is your suggestion in a situation like that. And then one last one. I believe this is from Redonda. I believe MAR is life-changing. It has been saving lives. The stigma in 12-step meetings is very sad. I had a participant that her medications were not metabolizing well and nearly overdosed because of it. So it sounds like two concerns of the overdosing on it.
All of those comments are great. Thank you all for your contributions. We're going to talk a little bit more about overdose risk, so I won't respond to that right now. But my impression is that it's really nice to see that there has been progress in terms of how many people have direct familiarity with somebody who's using MAR, and the way that shifts perceptions and reduces stigma. That's really great to see. In here, I put SAMSAs take on MAT, their definitive statement. This is the federal government Substance Abuse and Mental Health Services Administration, their take on medication-assisted treatment. They're talking here, they talk about MAR in the second part, but they don't use that terminology. So just to get us all cued in with what the federal government's take on MAT is, I'll just read it here. Medication-assisted treatment is the use of medications in combination with counseling and behavioral therapies to provide a whole patient approach to the treatment of substance use disorders. Medications used in MAT are approved by the Food and Drug Administration, and research shows that a combination of medication and therapy can successfully treat these disorders. And for some people struggling with addiction, MAT can help sustain recovery. And MAT is also used to prevent or reduce opioid overdose. So this, as I was reading it, it made me think of the comment that Brianna read about someone said it's like the medications plus counseling equals 1,000. That is the standard recommendation for the standard of treatment of opioid use disorders, is that three-legged approach, that not only the medications, but medications with behavioral treatment and also community sober support. However, there is some controversy. There have been studies that show that the medications on their own can be just as effective for some people, whether or not they participate in counseling and other services. So it's really up to the individual. But in general, MAT alone, not as part of a recovery program with the other two legs of the stool, is often considered more harm reduction than actual medication-assisted recovery. So let's talk about what some of the goals of MAT and MAR are. Sounds like a lot of you are familiar with these, and you've seen these goals taken on by some individuals you're familiar with. But MAT or MAR is a goal of it is to provide a kind of a scientifically based a new development of a pathway of recovery, along with additional tools for recovery, the medications as additional tools that can be used to support recovery, especially for those who have tried but haven't had success with other models. Maybe abstinence-based treatment without the support of medications hasn't worked for somebody, or they're just not able to get through the withdrawal, to endure the discomfort of withdrawal in order to attain sobriety. Also, to reduce overdose deaths. A lot of research has shown that both methadone and Suboxone reduces the risk of overdose in individuals who use those medications by over 50%. There is some concern that opioids, illicit opioids on top of these medications, especially methadone, can increase vulnerability for overdose. So that's a real concern also. Also, the medications, the goal of the medications is to reduce withdrawal discomfort and complications that keep people stuck in the addiction cycle. I mentioned that. Also, the medications should work to reduce cravings for opioids or alcohol, those urges and cravings that typically cause people to relapse despite their intentions to maintain sobriety. Also, the medications have a goal of increasing stability and safety for individuals who use, especially who use illicit substances, but also alcohol. For opioids, the medications should provide a way to eliminate the criminal activity that's necessary to acquire the illicit opioids and all of the chaos that comes into someone's life when they're seeking to get their illicit substances on the street. And if we're able to manage someone's, just keep them from feeling uncomfortable, manage their cravings to make them tolerable, and take away the need for them to participate in the illicit substance economy, they also have a chance to really increase their stability and to open up some free time in their life to possibly gain and maintain employment. There's a lot of time spent going after getting the resources necessary to purchase and then using and recovering from illicit substances. When you take the need for that away with the medication, there's a whole lot more opportunities each day. And also, a final goal of the medication-assisted recovery is to increase treatment retention, to keep people sober and to keep them in treatment in order to reduce their relapse potential. We know that substance use disorders, including alcohol use disorder, are considered to be chronic, lifelong relapsing conditions that will require some focus and management for the lifetime. When we use medications as part of a three-legged recovery plan, the evidence shows that helps keep people in treatment longer and reduces their relapses. So then the next question is, well, those are the goals for MAT. How does it actually perform in achieving those goals? I mentioned that there has been exhaustive research in many countries around the world about the effectiveness and safety of medications for the treatment of addictions. And I'm certainly not going to go through all of this today, but very happy to share this presentation with you if you're interested in doing a deeper dive into the research. Here, I just chose some of the sort of most the studies from leading researchers. So there's stuff here from the American Society of Addiction Medicine, the British Medical Journal, the National Institute on Drug Abuse, even the US Department of National Defense have all studied the efficacy and safety of medications for addiction treatment and published their results, and it's all very, very promising. So the outcomes basically of MAT, what we know are that it is now considered an evidence-based treatment. The medications, and including when it's in their use as part of a medication-assisted recovery, is clinically effective. It's the current standard of treatment. It's the first-line treatment. Medications save lives and they support individuals' stability and sustained sobriety. That's what the research really, the consensus that has been achieved through the research. In here, I'm gonna skip it to make sure we have time for everything else, but it's just sort of a summary on the outcomes of MAR. So the next section is about addressing some myths and misconceptions about MAR. Even one of these I even heard today in one of the comments already. So this first group, we have MAR is not a legitimate pathway to recovery. Another common misconception or perspective that's held by some in the recovery community is that if someone is on MAR, they're not really sober. They're not truly sober. They're using the medications as a crutch because they either don't have the strength or the willpower or the ability to actually achieve sobriety without them. Another one is that people doing MAR are just trading one addiction for another. What's the difference? Either you're addicted to heroin or you're dependent and addicted to your Suboxone. What's the difference? And the last one in this group is that MAR only delays and disrupts true recovery. So the idea that these medications actually just hinder people from achieving or participating in true recovery. So to talk back to these misconceptions or these perceptions about the medications, the clearest, most succinct response that I could formulate actually comes directly from the National Alliance of Recovery Residences, which has produced a very highly recommended guide. It's just 12 pages about helping recovery residences adapt to support people with MAR. And in that document, this is stated by NAR, by the National Alliance of Recovery Residences, that MAR is consistent with abstinent-based approaches to recovery. When an individual is taking their medication as prescribed, is not using illicit substances or alcohol, and is participating in a recovery program or community, that individual is fulfilling the expectations of an abstinence-based approach. Medications are essential for some people to manage cravings and engage effectively in long-term recovery. So as an advocate for MAR, the National Alliance of Recovery Residences is pretty progressive. And I agree with their stance that somebody who is using MAR and not using illicit substances, not misusing the medications, they should be considered sober, just as one would who has achieved sobriety from alcohol or opioids or stimulants, but they're continuing to take medications for another condition to help manage that. So a couple more myths and misconceptions. First of all, I want to address the one in green on the left side, that MAR should only be used for a short time. It's hard to think about where did this idea come from, but I think the idea came from that it's understandable at the beginning of sobriety, at the beginning of recovery, that somebody might need the assistance of medications, but after they get through the withdrawal phase, it would be best for them also to taper off the medication. But what actually the evidence supports is that longer treatment equals better outcomes for these medications. Relapses and overdoses happen when somebody is encouraged or decides to taper off the medications before it's actually clinically indicated. That's especially tragic if they feel pressure or encouragement from others in the recovery community to do so. It actually threatens their continued recovery. There is no research that supports the use of MAR only for a short time or a predetermined set of time. This is a decision that should be made between the individual who's taking the medications and their treatment team, their prescribers. And the standard of care is actually to continue providing prescriptions for the medications as long as they are useful for the individual. The medications themselves are safe, have very low incidence of side effects, and the side effects that there are pretty mild, especially when you compare them to the side effects of an active substance use disorder. And there are no long-term dangers or negative effects of using these medications biologically or physiologically. So there's from a medical standpoint, there's really no no need and certainly no urgency to encourage someone to discontinue the medications as long as the individual still finds them useful for their sobriety. And also this, we heard about this, about the overdose risk, some concern that somebody might overdose. It is very unlikely. It's actually, I would say, impossible for someone to overdose if they are using medications as prescribed, as part of medication-assisted recovery. That means not misusing the medication and on a therapeutic correct dose. There is no research that supports that methadone or Suboxone increases an individual's risk for overdose. Actually, a review of studies by Pew Charitable Trust in 2020 concluded that individuals prescribed therapeutic doses of methadone and buprenorphine have a significantly reduced risk of opioid overdose compared to those who are using illicit opioids. The research is not as conclusive. Oh, and the actual reduction in risk for opioid overdose for people who are on the medications is about 50% reduction. The research is less conclusive when we're talking about the medication Vivitrol. But for methadone and buprenorphine, the two primary forms of medication for opioid use disorder, they actually reduce very significantly the risk of overdose. Suboxone, actually, one of the two active ingredients in Suboxone is naloxone, which is the generic name for Narcan, which is an overdose reversal drug. And the reason that naloxone is part of the Suboxone formulation is so that if somebody takes their Suboxone, which includes naloxone into their system, and then takes illicit opiates on top of that, the naloxone should reject the additional opioids and put the person directly into withdrawal. Also, if Suboxone is misused, Suboxone can be dissolved and injected to get all of the effects of the Suboxone into the system much faster. But the naloxone also prevents people from injecting it, because if they do so, then the naloxone is activated and it would put the person into withdrawal. So it would be counterproductive to try to do so. With methadone is a little bit, if you had an unlimited supply of methadone, it would definitely be possible to overdose on methadone. But methadone is an incredibly controlled substance. It's not available at pharmacies. People aren't able to get a large number of doses to go. You basically need to go to the opioid treatment center at least 6 days a week in general to begin with, 6 days a week to get your one dose per day, and then one carry home for the weekend. So it's very unlikely that somebody who's using these medications as prescribed could even possibly overdose. Okay, so moving on into some of the more details about the medications. Don't worry, I know there's a lot of text here. I'm going to try to make it easy and summarize the main points or the main characteristics of each of these three medications. But to begin with, it's good to build a familiarity with just the names of the medications. The first one is methadone. That is sort of the old standby, the grandpa of medication-assisted treatment or medication-assisted recovery. Methadone has been around since 1965. It was actually synthesized in the 40s in Germany, and the first opioid treatment center in the US started dispensing methadone in New York City in 1965. The next one is buprenorphine, which is the generic name. Most commonly, the brand name is Suboxone. That's the most common formulation. And Suboxone is buprenorphine plus the naloxone or Narcan to prevent misuse. And that is becoming, it's a more convenient option for many people than methadone, because Suboxone can be, even for someone with a new prescription, it's pretty standard to give somebody a week's prescription at a time. And then finally, there's naltrexone or Vivitrol, which of these three medications for opioid use disorder, Vivitrol tends to be the least controversial because it is not an opioid replacement therapy. It's actually a complete opioid blocker. But let's circle back. Let's talk about methadone first. So I'm just going to show you this slide. If you see the picture in the lower left hand, the red liquid in the cup, that is methadone. Sometimes it's instead of it being a red liquid, it can be a gel or like a jelly candy that dissolves in the mouth, and it can be red or green. So methadone is actually a full opioid medication. It is a synthetic, clinically manufactured opioid medication that works for somebody who has opioid dependence. It prevents cravings and prevents them from going into withdrawal by filling their opioid receptors. The thing about methadone that makes it effective as a medication is that it's a long-acting opioid. So you really just need one therapeutic dose for 24 hours to keep you from experiencing any symptoms of opioid withdrawal or cravings to use additional opioids. It basically satisfies your opioid receptors with an opioid that keeps you from feeling the discomfort, but also at the right dose doesn't get you high. You're not going to experience intense euphoria or strong sedation or other of the pleasurable effects of opioids with methadone if used correctly. The sticking point about methadone is that it takes a lot of work and structure to stay on methadone. Methadone is only prescribed and only distributed by state licensed opioid treatment programs. In King County, Evergreen Treatment Services is one of the major ones, along with CMAR. And as I mentioned, initial prescriptions, folks usually need to go 6 days a week. You go every morning to get your dose. You're good for the day. You can get on with your life, and you go back the next morning to get your dose. People are not given, it's not standard to give people more than the dose that they need for that day. Because it can be misused. If you use more methadone on top of methadone, it will increase the effects of the opioid medication. As far as whether counseling, drug testing, and support is required for folks who are prescribed methadone, regular urine testing and counseling at the opioid treatment program is required to stay on methadone. And additional supports like support groups or mental health or behavioral health, emotional counseling are recommended, but generally not required. So the next medication, the one in the middle, Suboxone, or generic name buprenorphine, is a much more recent development. It was approved for use for the treatment of opioid use disorder in 2002. So it's now about the 20th anniversary of Suboxone. And what is really the development about Suboxone is that it's not a full opioid medication. It's a partial opioid medication. So it does attach to the opioid receptors in the brain, but it only turns on the opioid receptors or activates them about 40 to 50%. However, it completely fills the opioid receptors. So once someone takes Suboxone, their opioid receptors are full of the mild Suboxone, which then means that theoretically you shouldn't be able to get higher by doing additional opioids on top of the Suboxone. So Suboxone, like methadone, is long-acting. It also has a milder effect. There are different formulations of Suboxone. Most commonly, it's a film, a little strip of dissolvable film, or a tablet that is dissolved under the tongue. It gets into the veins underneath the thin membrane of skin underneath the tongue, and that's how it gets into the system. The picture here in the lower left in the center, you can see what a little Suboxone strip looks like, the sublingual film version. And for that film, it can be taken 1 to 3 times per day under the tongue, depending on the individual. There's also a monthly injection form of Suboxone called, the trade name is Sublocade. And there's even a 6-month implant of Suboxone or of buprenorphine called Probufene. And for buprenorphine, it's becoming more and more possible to get buprenorphine, to get prescriptions for buprenorphine outside of opioid treatment programs. So in order to prescribe buprenorphine for the treatment of opioid use disorder, you need to be a physician assistant, or an advanced registered nurse practitioner. But the medication itself can be picked up from pharmacies quite easily. Usually the prescription to begin with is for a week at the beginning, and then people can get a longer prescription fill over time once they've shown negative urine screens for illicit substances. So with buprenorphine, most providers require urine testing, and some require counseling and or support. But if for somebody who's really just interested in using buprenorphine as a harm reduction tool, not to actually stop their use of opioids completely, but to maybe supplement their use of opioids or reduce their use of illicit opioids by using Suboxone some days or sometimes, it is not difficult to find a provider who will in true harm reduction philosophy not require counseling or support if the individual doesn't desire it. They might not feel at home. Obviously, you can imagine in a 12-step meeting if they're using buprenorphine as a harm reduction tool rather than a tool for sobriety. And finally, Vivitrol or naltrexone. This is the one that's actually the opioid blocker. For naltrexone, somebody needs to be completely detoxed from opioids before you take the first dose. It generally takes about 6 to 10 days to get all of the opioids completely out of someone's system. Then they're able to be administered their first dose of Vivitrol, which actually acts to cap their opioid receptors. It sort of puts a temporary hat on the opioid receptor, so that if somebody were to do opioids on top of their naltrexone, there would be no receptor for those morphine molecules to attach to, and they wouldn't get high. It really takes away the reward or the effect of doing opioids. There's a new movie, I think, that came out last year called 4 Good Days, with Glenn Close playing the mother of a young woman with an opioid use disorder who is trying to maintain enough sobriety, trying to stay away from using illicit opioids long enough to be able to get her first dose of Vivitrol. That would be a very interesting movie to watch in a group, especially as an introduction to discussion about medication-assisted recovery. With naltrexone, it is a monthly injection in the butt, in the gluteus muscle. And any medical provider who's licensed to prescribe medication can prescribe the naltrexone. People need to go into their clinic or their opioid treatment program to actually get the injection once a month. One of the downsides of naltrexone is that people can feel confident after a month or two of not having cravings for opioids while they're on naltrexone, and they can think, you know what, I'm feeling good. I'm not tempted to use opioids. I don't think I even need the naltrexone anymore. And then they don't keep their follow-up appointment to get their booster shot, if you will, and that's when problems can come in with relapsing. Also, because somebody would have completely no tolerance for opioids in their system anymore, if they were to go back to using their same standard dose of say, heroin, after being on naltrexone, they would be in danger for overdose. Okay, so that is just a quick summary of those. I have additional slides in here that I would review if we were able to do a longer presentation, a longer time together this morning, but we're going to have to skip it for this time, so we have time to get to everything else. So this next section is a review of medications for alcohol use disorder. Just some really relevant, interesting points about medications for AUD or alcohol use disorder that I found from SAMSA are that of the 18 million people who met criteria to be diagnosed with alcohol use disorder in 2013, less than 7% received any type of formal treatment. So that's not 7% received medications for alcohol use disorder. It's less than 7% received any type of formal treatment, being referred to either outpatient or inpatient treatment or for medications. There are, just as there are for opioid use disorder, there are also 3 medications that are approved by the Food and Drug Administration for the treatment of AUD. And SAMSA's position is that medications currently are severely underused in the treatment of alcohol use disorder. They're not used as much as they could be. And for all of the medications that treat alcohol use disorder, they share these characteristics. They are not considered a cure for alcoholism on their own. They can keep somebody sober, but that does not cure the alcoholism. Also, unlike 2 of the 3 medications for opioid use disorder, the medications for alcohol use disorder are not alcohol substitution drugs. They are also not addictive or habit forming. They don't prolong or continue someone's dependence on alcohol. The recommendation is that they should be prescribed in conjunction with counseling and sober supports, the 3-legged stool. And also that all of these medications for alcohol use disorder are shown to have better results when somebody is able to maintain abstinence on their own, either in a detox program or otherwise, for 4 to 7 days before they take their initial dose of their medication. So here's the 3 medications for alcohol use disorder. We'll go through in order. So the first one is a comprosate, and I don't have pictures of 2 of these 3 medications, the acomprosate or the antabuse, the disulfiram, because they're just white circular pills. They don't look that interesting. But for the first one, acomprosate, or the common brand name is Comprol, it supports sustained abstinence from alcohol by restoring the natural balance of chemicals in the brain. There's quite a lot of changes in the neural system from alcohol use disorder, from the consumption of alcohol. And the acomprosate basically restores the natural balance. It helps somebody get back to homeostasis rather than allostasis with the alcohol. And that works to reduce cravings and control urges for alcohol. The acomprosate has been around since 2004. There's no risk of overdose. There's no abuse potential with acomprosate. And it is taken by mouth 3 times a day. And one of the characteristics about this medication is that it has the best effectiveness if it's taken at the same time every day. So there is sort of a strict regimen with this. You can understand that on its own, this probably wouldn't be as effective for somebody seeking to maintain abstinence from alcohol on its own. But the idea is that it helps them feel better in their brain and physiologically, so it reduces the drivers that keep them going back to alcohol. The next one, disulfiram, is known as antabuse most commonly. This one is, from my perspective, in my experience, this is the one that most people think of or have some familiarity with when we talk about medications for alcohol use disorder. Antabuse is the one that makes people violently sick if they do drink more alcohol after taking the medication. Disulfiram really enforces sobriety to give someone a chance to engage effectively in supportive and therapeutic treatment. The medication works to inhibit the metabolization of alcohol. So if you take your antabuse and later that day or directly after you have a beer or a glass of wine or a cocktail, you're going to get a severely unpleasant reaction. It's going to cause nausea, heart palpitations, sweating. Some people have profuse vomiting. Basically, this is it works on concepts of positive and negative encouragement. That's not the term. I'm thinking of reinforcement. This is negative reinforcement. It teaches somebody that if they drink alcohol, they get severely ill. It's very unpleasant. You create a negative association with alcohol. You want to stay away from it. You don't want to cause yourself to be ill from the alcohol. The downside of this is that folks who are not highly motivated, they can just decide, I want to drink. I think I want to drink later today. I'm not going to take my medication today. So the compliance can be poor, or adherence with this medication can be poor, and supervision is recommended for many who have difficulty being motivated to take their medication every day. This medication in particular can be prescribed for short-term use. This is not a medication for opioid use disorder. So this is different from what we were saying. There's no evidence that supports the short-term use of medications for opioid use disorder. However, for this medication, disulfiram, for alcohol use disorder, it can be prescribed short-term for somebody who knows that they're going to be in a situation where they're likely to have temptation to drink, like a high school reunion or a family event. If they know in advance other people are going to be drinking, I might be pressured to drink. It might be difficult for me to avoid the temptation. I know there's a medication that if I take it, it's going to make me really sick if I then drink alcohol, and I don't want to drink alcohol. So I want to get a couple days prescription of disulfiram. That is possible. Disulfiram was approved by the FDA in 1951. It's been around a long time, and there is no abuse potential. Somebody should be highly motivated if they're going to be on this, and it should not be given to anyone while they are still under the effects of alcohol and can't make the decision on their own to take this. The final and third medication for alcohol use disorder, hopefully it's going to sound familiar, it's naltrexone, which is, yes, also the same medication can be used for opioid use disorder. Naltrexone is the opioid blocker. You have to be completely, have all opioids out of your system. You then take the naltrexone and it creates that cap over your opioid receptors. There is not, we don't fully understand how naltrexone works to reduce cravings for alcohol, as the actual, it's actually acting on the opioid receptors. But the effect of the naltrexone also reduces one's urge to consume alcohol, and it takes away the pleasure or the reward. If you take Vivitrol and you then drink alcohol, you're not going to get violently ill like you would with disulfiram, but it's going to take away the pleasure. You're not going to feel any of the euphoria or the pleasant effects of the alcohol. It's really, you can drink, but there's no advantage to drinking alcohol over drinking Coca-Cola or water. You're not going to feel any different. So that's how the naltrexone works. And there are two formulations. There's a tablet that can be taken daily. The common brand name for the daily tablet is Revia. And there's also the long-term 30-day injection, most commonly called Vivitrol. The oral form was approved in 1994 and the injection was approved in 2006. If somebody is prescribed opioid painkillers, they cannot receive naltrexone because the opioid the prescribed opioid pain medication would not have an opioid receptor to attach to after the person is already on the naltrexone. So it's contraindicated for people who need prescriptions for opioid painkillers. Also, if somebody is trying to get their alcohol use under control or ceased, but they are continuing to use illicit opioids, then naltrexone would not be a good option. Okay, I've been talking a lot. I anticipate there's more questions about the medications, but I'm going to ask you to hold on to them for now, because I want to make sure we have plenty of time to get to this section, this next section, which is specifically focused on MAR in recovery residences, so MAR in RRs. And I want to give credit and call some attention to this publication you see on the left side from the National Alliance for Recovery Residences. This is NAR's guide and publication to help recovery residence operators adapt to having residents on MAR in their homes. And there's a link here in the slide. This is available from the NAR website. And a lot of the information that in the next 5 slides is adapted directly from this publication. So for some background context about MAR in recovery residences, we know that traditionally recovery residences have reflected and been influenced by the culture of recovery communities. Which have historically been abstinence-based, 12-step or faith-based communities that hold concepts of recovery and sobriety that do not include the use of medications. So that's sort of the background on the formation of the culture of recovery residences in regards to medications. However, current best practices are that recovery residences should foster inclusive, welcoming, and safe environments for all, regardless of whether or not that person is using MAR. And also that discrimination should not occur. Recovery residences should not accept or reject any applicant based on their MAR status. And to do so would actually be a violation of the Federal Fair Housing Act and or the Americans with Disabilities Act. So that being said, the next slide is tips for screening and evaluating potential residents who are on MAR or who are doing MAR. So a lot of these tips for screening and evaluating potential MAR residents are exactly the same for screening residents who are not on MAR. Your screening and evaluating interviewing procedures should be consistent, fair, and documented for all residents, regardless of their MAR status. We shouldn't be asking additional questions or more probing questions to potential residents who are using MAR that we're not asking of folks who aren't using the medications. And the next tip is to avoid exclusions based on the use of any type of prescribed medication, because to do so is a violation of federal law. So that whether or not they are on prescribed MAR should not be the basis for their exclusion from your home. Of course, the applicant's recovery goals should align with your recovery residence's philosophy and the services and support that you can offer, regardless of their MAR status. This goes back to, I'm thinking of a connection to the scenario where someone is using MAR really as harm reduction, not because they intend to totally cease their use of illicit opioids or alcohol, but just because they want to reduce it or space out their use. Probably their goals would not align with the goals of your recovery residence, and a different form of housing or housing support program would be more appropriate for that person rather than a recovery residence. Over here in the green, as part of your discussion with an applicant to be a resident in your home who is using MAR, it's beneficial to make it clear during the initial interview and conversation that all residents, regardless of MAR status, are expected to participate in recovery programs and all residents' activities. There's basically residents with MAR have the same responsibilities and expectations to be accountable to the community and for their recovery. No one should be able to say, well, I'm on buprenorphine or I'm on Vivitrol, so I'm unlikely to use. I don't feel like I need to go or want to go to any support groups or other treatment. That's not a recommendation, because that would not support the use of MAR as a three-legged approach to treating the disorder. Also, it's good to inform applicants up front that they may be asked to give their recovery resident staff permission to communicate with their MAR prescriber, with their treatment team. If somebody is unwilling to do that, that there might need to be more discussion, and also explanation about why the staff or the operator of the recovery residence may need to communicate or share information with the person's MAR provider. We'll talk about that more in another slide. And finally, all applicants should know and have a clear idea of what your residence's medication management policies and procedures are. It's it's understandable that if somebody is on a medication that they need to take daily to prevent them from experiencing symptoms of withdrawal or cravings to use again, they're going to have some anxiety or some concerns about who holds my medication, who keeps it, how and when do I have access to it. All of that should be part of your medication management policies, and you should be able to explain it to the applicant. So now let's look at three specific topics a little closer, three specific topics that are related to MAR in recovery residences. We've touched on this a little bit already. This slide is about the value and importance of coordinating with MAR providers. So we see here this nurse, she looks very friendly and relaxed, and hopefully any representative of a MAR treatment program or MAR clinic or opioid treatment program, they would be just as friendly and eager to talk with you. I have heard anecdotally there are some not necessarily recovery residence staff or operators, but other sober support individuals and groups, and also members of other treatment teams that don't find it easy or don't find the prescribers very welcoming for their interaction. It's understandable that everybody is busy. There are also regulations in place about confidentiality and HIPAA requirements that make it more complicated. But it is recommended that recovery residence operators or staff members do have permission to build a relationship and share information with MAR providers. That being said, all treatment decisions, all decisions about the use of the medications should only be made between an individual and their prescriber or their treatment team. However, recovery residence staff need to have a clear understanding of a resident's dosing and length of prescription. Need to understand how much Suboxone should they be taking at one time, how many times per day, and also the length of their prescription. When are they going to need more? When do we need to be aware that they're close to running out, so we can help them be accountable to go back to get their refill or do what they need to do to touch base with their treatment team. We also need to understand the impact of the medications on a person's daily activities. The medications can have some individualized effects. For example, for some people who take Suboxone in the morning, they can experience a period of lethargy or just feel not very energetic for a while after that. In terms of understanding the individual impacts of the medications on a person's functioning, that's important to know, so we can know, is this reason to be concerned about someone, or is this how the medication typically affects them? Also, it's important to have a clear understanding of the potential negative or concerning effects of the medication. What are the signs of somebody having a bad reaction to it? What other medications should they avoid because it has negative interactions with the MAR? For example, anyone using methadone or Suboxone should be very careful with any benzodiazepines or alcohol because they're all sedatives. They all have a depressant effect. So someone who's already taken their prescribed dose of methadone or Suboxone should be very careful about putting benzodiazepines or alcohol on top of that, even if it's prescribed benzodiazepines, because of the increased risk for respiratory failure. And so the next point, two-way communication. This is not only about recovery resident staff getting information from the clinic or from the MAR providers, but also about the recovery resident staff sharing information with the treatment team. So the individual who shared earlier that she has some concerns about someone using higher than a therapeutic dose of their medication because she's observed them nodding off. This would be an observation that could be appropriate to share with the treatment team to let them know that's happening. That could help inform their thinking or their decision about the dosing for the individual, or it could lead to a conversation. The treatment team might let the person know, well, we've also had some concerns. They've been on a high dose for a while, so we'll talk with them about what their actual goals are and what an appropriate dose might be, so that they're not nodding off, so that they're not having concerning behaviors. Because of HIPAA laws, because health information of an individual is private and protected, you will need to have a legal document. It's that sounds scary, but it's usually called a release of information or mutual release of information that you will need to have between you or your recovery residents and the treatment team, that needs to be signed by the resident, by the patient, by the person who has prescribed MAR. So that it's documented that they have given you and their treatment team the permission to coordinate and share information about their treatment. There's a link here on this slide to a sample of that, of such a document, a release of information. But also, it's also all clinics and MAR providers should have their own version of that document. So you can also ask them for that document and complete it with the resident, and then get it squared away that way. The next topic is also very important. It's about preventing diversion, preventing basically the unregulated distribution of these medications. When we're talking about diversion, we're really, or risk of diversion, we're really only talking about two of the medications, buprenorphine and methadone, or Suboxone and methadone. Those are the two medications, both of which are for opioid use disorder, that do have street value and potential for misuse. Because methadone is a full opioid and Suboxone is a partial opioid. They can be misused to get high. They can also be sold to those who are not actually prescribed the medications. So this is very important for the safety and well-being, not only of you and your recovery resident staff, but also just members of the community. We're not going to have time to go into the ways that people find to divert their methadone or their Suboxone, or the ways that they are able to distribute it on the street. But this is a very important issue that recovery residences need to be aware of and need to have covered in their med management policies and procedures. That all staff of the recovery residence obviously need thorough training on, and I would suggest periodic review of the medication policies and procedures. It's not a bad idea to consider lock boxes for medications if you don't have them already, especially if a resident is prescribed either methadone or buprenorphine. It's important that residents do have access to their prescribed medications. So if it's in a lockbox, for example, and there's 2 keys, one of the keys should definitely be with the resident and the other one could be kept by the resident staff. Otherwise, combinations work where the resident knows the combination for their medication box. It's also a big part of preventing diversion or preventing the misuse of these medications, specifically methadone and buprenorphine, is to be aware of the behavioral warning signs of inappropriate dose or the misuse of the meds. So this picture here, over here on the right, this man bent over, that I tried to find a good picture of someone nodding off. It usually, the characteristics of someone nodding off due to opioid sedation are that it's difficult to wake them up, and they're frequently sleeping or appear to be passed out in a bizarre or unusual position. So this would definitely be a warning sign of inappropriate dosing, excessive dosing, or the misuse of the medications. Other warning signs besides drowsiness or nodding are just general lethargy, lack of energy, lack of motivation to do much, mood changes that are observable, and also disengagement from interacting with other people or activities. Also, finally, a very good tip for preventing diversion. This should also be done at the clinic or the opioid treatment program, but regular med checks med checks and also random drug testing. The drug testing should also be performed regularly by the clinic or the MAR provider program. Med checks refers to knowing how much Suboxone someone should have at any one time, knowing that they only get a week's worth at a time. They take 3 strips a day. So that's 21 strips per week. They picked up their refill on Friday. Today is Monday. How many strips should they have left at this point in time? That is a med check. That's checking that they're not overdosing or selling their medication or otherwise diverting it. And for drug testing, some people commonly ask, well, if we do a drug test and methadone is an opioid, and their drug test turns out positive for opioids, how do we know? Should we believe them that they're positive for opioids only from methadone, or is it from illicit opioids? Actually, it's very common that methadone and buprenorphine are not included in the screen for opioids. They're separate categories. So it's likely that the UAs you already use might have those separated out. If not, they're available and they're affordable drug screens that basically differentiate between different forms of opioids, whether it's illicit opioids, buprenorphine, or methadone. Okay, we are running out of time. So glad that we're on the last slide in this section, but this is about fostering a MAR welcoming culture at your recovery residence and in your community. The objective here is really to educate others, educate other residents of your home and your staff about MAR, and to demonstrate an open-mindedness about MAR and the acceptance of MAR as a viable pathway to recovery for some. The objective is not to encourage anyone in particular or any individual necessarily to take MAR medications, but rather to share information in an objective and open-minded way. A really important point that I recommend is to have open and honest discussions with both staff and with residents about their concerns about MAR, or living or working in a residence with folks who are on MAR, and seek to preemptively problem solve collaboratively. Also educating staff and residents about MAR, residents who are not on MAR, but providing basic information about MAR and sharing some success stories can really generate compassion and change hearts and minds. Make the recovery community more welcoming in general for folks on MAR. Okay, so I know we're down to just the last couple minutes, but I would love to open it up for some questions and discussions. You can also, on this slide, you have my email here. You are very welcome to contact me with additional questions or to ask for resources or to receive a copy of this presentation. I just want to show you the very last slide here has links to some very good resources and research about MAR. So if you'd like to get a copy of this presentation so you have those links, just reach out to either Brianna, Jason, or myself, and we'll be happy to share it with you. In the meantime, I'd love to hear some of your questions. Either Brianna can read them out from the chat box or feel free to unmute yourself.
Thanks, Garrett. I know we had a couple of people asking just how beneficial this presentation was and how they wanted the slides. So I told them I would ask them, but you answered that. So that's great. So all those who are wanting the slides, I will put my email down, and it's Garrett's emails right there as well, and we'll get them for you. Yeah, Garrett, there was one question from Sean, and I kind of had a question to add on to that, to kind of expand to his question, but he said that he understands that people are not going to OD on Suboxone or Methadone if they take it as prescribed, but his worry is about the additional use of illicit substances at the same time or immediately after. And it says that it's affecting his decision-making regarding authorizing particular ASAM level of care sometimes. And I guess my personal question to follow up with that is there a difference really? Are they more likely to have a higher risk of relapse, somebody who's been free of substances without MAT compared to somebody who has used MAT? Because isn't that kind of the same if they're free from substances for a certain amount of time, regardless if they're on MAT, they're still going to have a really high potential for overdosing, correct? I don't, maybe, but that was just my question in addition to
him. The sort of the built-in overdose safeguard with the medications are that for methadone, yes, with methadone, if someone were to use additional illicit opioids after they take their methadone, they could get more effects. They could get higher, basically. The methadone at the appropriate therapeutic dose should not make them high. It should just keep them comfortable, keep them from experiencing symptoms of withdrawal or cravings. If they were to do heroin, say, right after they do their methadone, yes, that would make them high. That could increase their risk for overdose. However, the idea with methadone is that the therapeutic dose makes it unnecessary to do additional opioids. If you are motivated for sobriety from illicit opioids, you manage your addiction by going to take your medicine, taking your methadone in the morning. You then don't have to use illicit opioids in order to feel better, to reduce the discomfort of withdrawal. For Suboxone, or buprenorphine, especially the Suboxone formulation that includes naloxone, the naloxone is there so that basically the naloxone will kick off any illicit opioids from the opioid receptors once they're in the system. So someone takes Suboxone, it actually makes it pretty inconvenient to do additional illicit opioids on top of Suboxone. In terms of relapses,
I can't even get my screen to come back. I'm hoping I'm not for your Surface Pro.
Okay, well, mute her. But in terms of relapses, the research shows that people on MAR have reduced incidences of relapse because the medications basically keep their cravings, keep their urges under control. They're able to focus on other things and not obsess about using illicit substances.
I'm not I'm not seeing any more questions in the chat, but you guys feel free to ask Garrett.
Okay, I'm quickly going through. Oh, I see. I'm looking at the chats now. Somebody mentioned there may be another additional medication for alcohol use disorder that I'm unaware of called Topramate. Some people shared. Okay, somebody asked. Somebody asked if we can just share emails in the chat. So I'm going to put my email in there in the chat box now. If you have questions you'd like to ask me directly. Oh, I see Jason did that also. Thank you. Okay, Steve asked, Jason specifically, does Walker have a MAT or MAR sample house policy? Jason, can you respond to that?
Yes, yeah, absolutely. Stephen, most definitely a lot of the providers out there currently that are Walker certified have, what do I want to say, a wide range of policies and procedures out there concerning MAT. MAT and MAR as a whole. I will gladly email you some templates and some of the current policies out there that our individual housing providers are using.
Yeah, I just wanted to make a comment too, Jason. I think you accidentally sent them the wrong email. It's actually certification@walker.org to contact me.
Yeah, I did, and I realized that after I sent that. If you could retype that in there for them, I apologize.
I just want to let people know in case they grabbed that one. It's actually certification@walker.org. Oops, I sent that to Steve instead of everyone. All right.
Everybody knows the Walker website, waqrr.org. That's a good way to get in touch with us. Also, if you have questions, and you should be able to find a link to this recorded presentation on the website also. So somebody also sent in a comment about MAT for meth, or medication-assisted treatment for stimulant use disorders. That's sort of a development. I don't believe any of those medications have been approved by the FDA, but there is a lot of hopeful research. I would be very happy, and a lot of people would be very eager to see a medication approved to assist with stimulant use disorder. Mm-hmm.
And for those of you that are interested, I came across another treatment out there that if it has not, I want to say they just recently got formal FDA approval for opioid use disorder, and it's called Sparrow. I won't go into a great detail, and I'm just learning about it myself. But it's actually a device that goes behind the ear, and it works at interrupting some of the receptors and the signals that get sent back and forth. It's pretty interesting if some of you have the time to read up on it.
Nice.
All right, so I would be very happy to continue having discussions about this topic, but I believe we're out of time. So please reach out if you have questions, or if there's issues that you're interested in hearing more about that we didn't have time to cover today. That's all very helpful feedback, and can help us target these presentations to be of the most use and interest to you all.
Thank you so much, Garrett. Yeah. This was really great webinar.
Thank you so much, Garrett. On behalf of Walker, I want to thank all of you guys for taking time out of your day to join us today. We'll have a lot of great trainings and such coming up here in the next few months, including one on mental health, CPR, and first aid. Again, I want to thank all of you, and until next time, be safe and be well.